Hello, my name is Stijn de Mot and this is the Smart Education podcast. Great to have you back with us. Today we have a brand new episode on the podcast and we will have a chat with Michael Rathleff. Michael is an associate professor at Aalborg University in Denmark. He is also a clinical researcher with a background in physiotherapy. We recently organized a course with Michael and his colleague Henrik Riel about the management of plantar heel pain. And that happens to be the main topic of today's podcast. Let's listen to it right now. Welcome, Michael.
Thank you very much.
Michael, maybe it's good to share with the listeners your small introduction of yourself. And then can you tell us a little bit about your main focus of interest when it comes to research? And afterwards, maybe also some passions you might have.
So I work at the research unit for general practice in Aalborg, where I head the research group called OptiYouth, focusing on optimizing physical health in youth. So a lot of my research is actually focused on improving physical health of youth. But the other stream of my research is on these common lower limb tendinopathies, patellar tendinopathy, plantar fasciitis, plantar fasciopathy, whatever we might call it today. And then one day every week, I work at the physiotherapy department at Aalborg University Hospital. And if I should have like one key passion of mine within research, it's about how to make sure that our research actually influence clinical practice, how to make sure that our research is clinically applicable.
We'll touch on that later, but when I asked about your passions, I meant just in daily life. Or is research your daily life?
I think whenever you ask the research about like what's work and what's not work, everything just melts together. And I think most researchers will say that, yeah, my best ideas came during a run, during something where I wasn't doing research per se. But one of my passions definitely running. The best thing is trail running. If I can sneak off and run in the woods where there's mountains, where you can get some solitude, some alone time, and some amazing sceneries, that would be my passion when it's not research.
Okay. Thank you for introducing yourself. Maybe to tell the listeners why we have you here today on the podcast is that you're doing a course here with us with Smart Education. And the course is about plantar heel pain. We're very glad that you wanted to share with us some other interests about the plantar heel pain. Based on and what I wanted to ask as a first question, based on the research you have done together with your colleague Henrik Riel, who is here today with you as well, what are the guidelines you can give to our listeners who are mainly physios and healthcare providers towards the treatment of plantar fasciopathy? So can you please give us a few rules of thumb that you mentioned today in the course as well?
I think for me, who's been interested in it for a number of years, the biggest change is that we start to think of this as instead of passive intervention, like only insoles, we start to think of it more as a tendinopathy in some way, that we need to also expose the plantar fascia to loads, that the whole current thinking about how we manage tendinopathies also apply to plantar fasciopathy. And for me, that has been one of the biggest game changers when I've seen patients to think more in terms of loading programs and what we would normally do for Achilles and patellar tendinopathies. So I think one of the key things here that we've been discussing today is the resemblance to other tendinopathies, and also how you can use loading programs as part of your intervention for these patients. But of course, the exercise and the loading protocols are only part of it. The second part is the whole education side of things and the load management. I like the idea that we have these Susan and John, two prototypical cases that went on through the day, where John was this young sports active runner who's increased his training volume quite dramatically during the last 4 weeks, whereas Susan is this 55-year-old nurse with a high BMI, lots of standing work. And when we talk about loading protocols, that's part of it. But if we don't get John to manage his training load, educate him on how to reduce but not stop his running, slowly progress from there and give him some tools and guidance to do that, that's an important clinical take home as well. And for Susan, it's about managing or helping her managing her job. How can we help her instead of being on her feet for 8 or 9 hours per day, can we convince her to talk to her boss about shift or getting paperwork for a period of time? So thinking that loading programs, but all the education is two sides that we need to think about when managing these patients. Yeah, exactly.
Yeah. Well, one of the take-home messages I recall from the course just a few hours ago was that you said, keep it simple. And I like that idea because that's what we should focus on, I think. And I wanted to ask you as well, besides to the education and the natural history of the plantar heel pain pathology, what is the evidence-based what does the research tell us about other interventions, which may be passive, like manual therapy, taping, orthosis, stuff like that? And please tell us what is your, besides keeping it simple, what could you recommend us with other treatment options, I should say?
I think in general, and maybe this is also my bias as a researcher and a clinician, I would always favor the active approaches. My aim would always be to both exercise, but also giving the patients the tools how to self-manage their condition. So basically saying, it's up to you. I want to give you the tools, but you're the one that needs to change behavior, needs to do these things to manage your pain complaint. So I would always favor this active approach, not only exercises, but in general, an active approach. The passive interventions, which also have evidence for their efficacy,
they have their place in the treatment plan.
I think we touched upon it today as well, but insoles, and we know that insoles, at least for the short term, is superior to placebo. We also have a quite good understanding that it doesn't seem to matter what kind of insoles you give people, if it's prefabricated heel cups, cheap, 10 euros, 5 euros, or if you go for more expensive orthotics that are customized, doesn't appear to be a difference in
value.
Yeah, exactly. And that's one of the interventions where I think we should go for the simple, cheap approach as well. And we also have evidence for the short-term effect of taping. And I think that's, if you have this runner who's just so keen on running his 5K or his 10K in a couple of weeks, I think taping is one of these options which provides good, immediate, acute pain relief as well. Maybe will allow him to run it better compared to not.
Well, and what is important is that you can keep them active, you can keep them running.
And I think when we talk about managing chronic pain complaints, keeping them active is what should be one of our key priorities when we see all these patients, because we know they're in big risk of stopping sports, become less physically active, and then we suddenly have the extra burden of other diseases as well. So everything we can do to keep our patients active, that's what we should encourage.
So we should add not only keep it simple, but keep them active.
Exactly.
Yeah.
I think that's a really, really good point. And at least if I reflect back on some of the questions I've had from patients but it hurts when I'm active. Is that okay? And that is an important dialogue to have to your patients. Say, well, it's actually okay that it hurts a bit when you're out walking, when you're walking with your dog. That shouldn't be a barrier for you to keep active, to do some kind of physical activity. And maybe that's where we can also help the patient finding alternatives. So I can't run. Well, can you bicycle? Can you swim? Give them credible alternatives where they can keep active and even keep fit while they recover.
Okay. But still, in my experience with patients, there are treating the plantar heel pain is mainly a chronic, which is a chronic condition. It's not always as simple as it looks, and I'm sure there are a few common pitfalls that you can tell us a little bit about. So in other words, what are the main reasons why treatment sometimes fails and patients have a hard time recovering? I'm thinking of adherency, occupation, lifestyle stuff.
I think that's a really big and also interesting question, like why don't they recover?
Mm-hmm.
And today we had the approach of keeping it simple, these key components that we should be good at and focus on. But it's quite clear that that's not something that will benefit everybody. That's where we sometimes need to have second thoughts. And sometimes I think that there might be one reason why you got the pain complaint, but there might be other reasons why you still have it.
Mm-hmm.
At least in some of the patients I've seen with these very, very long-standing chronic pain complaints, they develop these worries and beliefs, and some that are very maladaptive. And I can see from when I was younger and so I really failed to go into that discussion with the patient and asking about, what do you worry about?
Mm-hmm.
What are your fears? Why do you think that you still have these pain complaints? And taking more time to actually ask questions and listen to the patient to uncover more than just the foot, but what's going on with this patient. That's one thing. And then another thing is the occupation, which you mentioned. I always think back to one of the guys working at the hospital, which was part of one of our research studies, and he was just forced to work up to 10 kilometers every day. And even though it was quite severe and painful for him, he was always aggravating his knee pain. We couldn't really find something that fit with like an insert or a taping that would allow him to work. So we started to use painkillers, NSAIDs and paracetamol in the morning to keep up with his work, because he was afraid of being fired if he couldn't keep up with his work.
Mm-hmm.
And there, I think, both him being exposed to this aggravating factor every day, but also his worries and fears about losing his job actually made everything much worse.
Mm-hmm.
And that's where simple things like a loading program doesn't make it. That's only one part.
I wanted to ask the load management, which is an important topic as well. How can we make it more objective? Because that's most of the time that's a problem for patients and for healthcare providers as well.
I totally agree. And one of the ways we've tried to make it more concrete when we say reduce load and then build up slowly again, which is an advice I've given a lot of time, is to make this activity ladder, which was basically developed for kids with patellofemoral pain. But I think the whole principle about having different activities on a ladder, going from something that's quite easy and then say to the patient, you can progress to the next step when your symptoms are below a certain threshold, and then teaching them how to get back based on their perception of symptoms. So more clearly say when they can progress to the next activity. Also for running, for example, could be one way to more objectify the reduce and then slowly build up again based on symptoms.
Mm-hmm. Okay, very nice. Well, maybe we can move on to another topic I wanted to address since we have you here on this podcast. People might know you, I know you, because you're very active on social media. And if you haven't heard of Michael Rathleff in the past on Twitter, I would recommend all listeners to follow you on Twitter. And that's why I found out that you're also involved in, I can describe it as a movement that wants to translate research to clinical practice. A very important task, in my opinion. And that's also a mission of our organization. But since you are here, I wanted to know your thoughts on that. Do you think, and that's an interesting question, do you think we're getting better in reaching that goal? And which information channels are the best to try to share that knowledge?
So first of all, this is related to Trek, which is largely driven by Christian Barton, and actually the idea of Trek originated when Christian and I had a couple of Belgian beers, Rochefort's 10s.
Okay.
Actually, it's a funny story.
All the best ideas, they start in Belgium or with Belgian beer. Yeah,
I think that is true. And that's been a passion from both of our sides from quite a few years now. If we look at the evidence, are we actually getting better? I know that one of the researchers, Sinead Holden, from our research unit, did a systematic review where we looked at how good are we actually at reporting the exercise interventions for patellofemoral pain. And we also looked at the association between how the reporting was 20 years ago and how it is today. Mm-hmm. And based on that, we don't really improve a lot.
Oops.
But I do think that with the increased focus on knowledge translation, there's different reporting guidelines like the TIGI and the CERT, and more we are encouraging people to record videos of their interventions, their training exercises, record videos of when they say, I'm doing an education session with a patient. Well, let's record it because that will make it easier for clinicians around the world to actually see what did you do? Because if you're having 30 minutes with a patient and saying you're giving patient education, it would be nice to know what is actually the content of this patient education session. So I think if we look back in 10 years' time and look at us today, I think we will improve, and it's much driven by this increased focus on transparent research reporting and also an increased focus in the general research area about research needs to be applicable and implementable afterwards. If we can't implement it or even depict what they actually did, then it's never going to change clinical practice. So I do think we will get better, but we're clearly not there yet.
Okay. And do you think social media channels like Twitter is a good way to try to translate and to bring that message across? Sharing infographics, small YouTube films, stuff like that?
Exactly. You're asking a big and important question here, because with the academic journals, in general, the research papers are a bit boring to read, plain text, a couple of figures. They're not going to help facilitate implementation. But I think the researchers need to think of this as a package. So the research publication might be something, but then in addition to the research paper, there needs to be videos, infographics, maybe podcasts with the authors to say this was our thoughts or ideas, and you can maybe have an interview with patients on how they perceived it. So we think not only as research being or outputted as a research paper, but being the research paper only being part of the bigger package that we as researchers need to deliver if we're trying to make clinically applicable research. And that is where I think Twitter comes in super handy together with social media, because it suddenly allows us to reach a lot of people very, very easily.
Okay, thank you. Maybe another example of that knowledge transfer is the leaflet about patellofemoral pain that you and together with Christian Barton developed. And it has been translated in 8 different languages. And you told me today maybe there's a next one, the 9th language coming, which is German. It's also in Dutch. We were very happy to be able to participate on that. And it's a fantastic tool, I think, to get good information, not only because we were talking about the getting knowledge across to the physios, but it's important to get that information as well to the patient. And that it underlines, I think, the importance of education, and that is an important role where an important role for physiotherapists lies. Do you think that physiotherapists need to do more on education and spend more time on education with their patients?
I definitely think we shouldn't underestimate the role of education and start to perceive ourselves as not just doing massage or not just prescribing exercises.
Massage, what is that? Massage?
Like manual therapy.
Okay.
That we need to think ourselves as more of also coaches and educators. But I think we also need to know what are the tools that we need to convey information to the patients and also make the patients transform this knowledge into changed behaviors. That's where I think these leaflets, apps, whatever, there's a whole area of new tools that we can use to actually facilitate this. And I think the patellofemoral pain leaflet is a good example, and we're coming up with new leaflets. We have some coming for Osgood Slatter, some new ones specifically for kids with knee pain and plantar heel pain as well. So that's one of the ways we want to translate our knowledge as well, to provide something meaningful for therapists and patients.
Okay. Well, I invite all listeners to give us just an email, sending it to info@smarteducation.be, and we will be very happy to send them some of those leaflets which they can use in their own practice. And we'll be happy to participate in translating new leaflets, so feel free to share that with us, and we will help to get this message across. As I said, which is already also a very big mission statement for us at Smart Education. Wrapping it up here, Michael, we need to head to the city center because we're hungry. I would love to thank you a lot, and not only you, but also Henrik, your colleague, for being here with us today, sharing your knowledge, and also sharing it with our listeners. And I hope to see you, let's say, next year for another podcast and some more information about education and exercise. Thank you very much.
Thank you.
So, we've reached the end of this podcast with Michael Rathleff. We hope you found it interesting, and we believe that you can take something out of it to use in your daily practice as a physiotherapist. We invite you to have listened to one of our other episodes, and we ask you to stay tuned in because there's a lot more coming. Please follow us on Twitter, Instagram, and Facebook, and our website for all the courses we deliver in Belgium and the Netherlands. See you soon!